So I will start the recording, and I'd like to introduce Dr. Jose Garcia. He's a professor in the Division of Gerontology and Geriatric Medicine at UW and Associate Director of the VA Puget Sound Geriatric Research, Education, and Clinical Center, also known as the GRECC. He's a practicing endocrinologist at the VA, and he's also a translational researcher working on the role of ghrelin and other anabolic therapies in regulating appetite and body composition in the setting of sarcopenic obesity and other wasting disorders, some incredibly important research. And he's going to talk with us today about thyroid disorders in older adults.
Thank you very much for that introduction and also for inviting me. It's a pleasure to be back to speak a topic that I think is very relevant. There it is. Okay, so the learning objectives for today include to be able to recognize the signs and symptoms of thyroid disease in the elderly, to increase our understanding of the different tools used to diagnose hypothyroidism, hyperthyroidism, and thyroid nodules in the elderly, probably the three most common conditions that you're going to encounter, and to increase our ability to implement treatments for hypothyroidism, hyperthyroidism, and thyroid nodules in the elderly. So I would like to start with a case, and the case that I'm going to present to you is 70 years old female patient that was admitted to the ICU with a diagnosis of congestive heart failure exacerbation.
Dr. Garcia, I just wanted to let you know that your audio is a little bit patchy, so I'm going to turn off the video so that we just see your slides. And if you have other programs on, you might want to close them down.
Okay, I actually don't have other.
All right, and we'll see how that goes.
Let's see. If it's still an issue and you want me to connect my like headphones, I can try that.
I'll let you know.
Perfect. So the patient is a 70-year-old female that was admitted to the ICU for CHF exacerbation. And she was diagnosed with atrial fibrillation with a heart rate of 58 and a blood pressure of 95/60. Patient underwent a cardiac cath showing clean, quote unquote, coronaries 1 month before admission. And upon exam, she was found to have irregular heartbeat with bilateral crackles on the lung exam and 2+ pleural edema. Also, she was found to have diffuse goiter, so an enlarged thyroid. So the question is, what test would you order? So some of the routine labs would include a CMP, comprehensive metabolic panel to check the kidney, the liver function, but also thyroid function test, including a TSH, thyroid stimulating hormone, that was found to be 0.4, so that is in the lower end of normal, and a free T4 that was 2, which is high, abnormal. Also, because of her finding of having a goiter on physical exam, she underwent an ultrasound that showed a diffuse enlarged thyroid with a 1.1 centimeter nodule. So what are the next steps? So I want you to keep this in mind, and we'll come back to this case at the end of my presentation. And maybe we can have a sort of a live discussion on this.
And
so
audio seems to be much better.
Okay, great. Thank you. So speaking about thyroid disorders in older adults, it's important to keep in mind the clinical presentation and diagnosis, because sometimes it can be atypical. So it may not be something that you've been taught in school or that you read on the books. Sometimes it's non-specific and can include things that are common in the elderly, such as decreased cognition, increased rate of falls, or decreased functionality overall. They're also usually associated with multiple comorbidities that can mask or alter the presentation, or sometimes mimicking thyroid disease. Sometimes these non-specific symptoms can be attributed to old age, and the diagnosis may be challenging. And so we have to rely on thyroid function test, which, for instance, in somebody who's in the hospital can be misleading because of what we call non-thyroidal illness. So we know that hormones change when we're acutely ill. So for instance, we're in the hospital. In this case, we see a CHF exacerbation like the patient I just presented. And so that may have an effect on thyroid function. So that is also important to keep in mind. But let's start with the clinical evaluation of thyroid disease. And it's important to recognize first those signs and symptoms that can reflect changes in function. So you can be hyperthyroid, which means to have too much thyroid hormone, hypothyroid, meaning to a decreased amount of thyroid hormone, or be in the normal range, or euthyroid. In addition to the physical exam, the two labs that are most commonly ordered include a TSH and a free T4. I already mentioned briefly the non-thyroid illness or CQ thyroid. So obviously, one of the things that we need to do is to examine the thyroid. And one advice that I give to providers usually, and this not only applies to thyroid, but to everything in general, is that if we don't examine normal thyroid, then we won't recognize with confidence when somebody has an abnormal thyroid. And so it is important to perform a thyroid exam as part of our routine physical exam when we examine patients. So when thyroids are enlarged, that's usually called goiter, and can be a diffuse goiter, meaning that you feel the gland is enlarged, but do not feel any discrete masses, or you could feel masses that could be a single mass, so a solitary nodule, or a diffuse or a number of masses. So that's called multinodular goiter. Most of the time, the presence of goiter will trigger the request of an ultrasound. It is important, as I was mentioning before, to take into account the age and comorbidities, as this can affect also the clinical presentation. So let's review the physiology of thyroid function. And this is probably one of the things that I most commonly see people struggling with that are not seeing patients with thyroid disease on a regular basis. And so this would be one of the things that I would like you to take home. So the thyroid hormone axis starts in the hypothalamus with what we call TRH secretion. So the hypothalamus will make this thyrotropin releasing hormone that will then act on the pituitary gland that will causing the release of TSH, thyroid stimulating hormone, that will then in turn go to the thyroid gland to cause the secretion of thyroid hormones. And that is free T4 that in turn gets converted into either the active hormone, free T3, or an inactive hormone called reverse T3. Usually the two that we're more commonly interested in is free T4, number one, and free T3. For the majority of patients, free T4 and TSH are sufficient. In fact, for screening purposes, and unless you suspect that somebody has a central problem, meaning a problem in the pituitary or the hypothalamus, we usually only screen with a TSH test. Most labs offer the option of doing what we call a TSH reflex. And what that is if the TSH is abnormal, then the lab will automatically add a free T4 to that lab. And that's actually a pretty good way to go about it. However, getting a TSH alone is not sufficient when you're suspecting pituitary or hypothalamic disease. Because if you don't have a signal in the brain, then this value of TSH will not reflect the thyroid function, and you need to get a free T4 levels in those cases. So we'll come back to this in a few slides. Free T3 can be ordered, but it's usually not done because unless you're critically ill, where you're looking at the rate of both free T3 and reverse T3. And so in most cases, just free T4 and TSH, as I was mentioning before, are sufficient tests. And let me change my pointer here. Okay. A few things that are important to keep in mind that happens with age is TSH may be slightly increased. Sometimes it's normal, but sometimes it's increased. There's also an increased chance of developing nodules and also a decrease in iodine and on free T4 secretion. So some of these things are physiologic. And so we may have a TSH, for instance, that instead of being 3 to 4, it may be a little bit above normal. And that doesn't necessarily mean that the patient is having a thyroid problem. So this slide represents just that. So you can see here how there's a range, the normal range for serum TSH, and it usually goes from 0.4 or 0.5 to about 5. When you have a suppressed TSH, a low TSH, that if your brain is intact means that you have too much thyroid hormone. And so that is called hyperthyroidism. That can be clinical if you have symptoms, or subclinical if you have a normal free T4 and you have a slightly decreased TSH. When you have non-thyroidal illness, which is represented here in the center, you can see how TSH can be from slightly decreased 0.1 to slightly increased to about 10 without reflecting necessarily a true thyroid condition. When you have hypothyroidism, which is what I was mentioning before, if your pituitary is intact and your hypothalamus is intact, your TSH is going to go above the normal range. But if you have a pituitary or hypothalamic problem, then your TSH can be normal or can be decreased, can be below the normal range. So as a result of this, when you see somebody with a central problem, either pituitary tumor, brain tumor, brain radiation, brain surgery, it is important to not overinterpret TSH and to get simultaneously a free T4. Another caveat that I will mention now is that sometimes patients with thyroid cancer are kept on purpose with a TSH that is suppressed, because that is known to decrease the rate of recurrence in thyroid cancer. And so patients are given, after thyroid surgery for thyroid cancer, supraphysiologic doses of thyroid hormone replacement in order to lower that TSH. And sometimes when those patients go to other specialties outside of endocrinology, the other providers tend to want to normalize the TSH, decreasing the dose of thyroid hormone. And by doing that, they're actually increasing the risk of recurrence of thyroid cancer. So it is important, and I would say as a rule of thumb, that whenever you have questions on somebody who is on thyroid hormone replacement after thyroid cancer, that you reach out to that patient's endocrinologist before changing the thyroid hormone dose. So TSH is the preferred test to use for screening purposes in the outpatient setting. But as I was mentioning before, it's not sufficient if you're sick or if you're suspecting a central process. What happens if you're sick? Well, TSH can go down, for instance, if you're taking steroids, if you're on vasopressors like dopamine, or simply if you're fasting. But it can also be increased when you're sick upon recovery. It's actually a good sign. So when your patients have an increase in TSH when they're recovering, that means that they're doing better. And this, of course, is transient and does not warrant any treatment. The only recommendation is to follow up with that patient maybe 4, 6, or 8 weeks afterwards, just to make sure the patient is okay and that the TSH is returning to the normal level. Free T4, the gold standard way to measure it is by equilibrium dialysis. However, most labs, unless you specifically require or request that equilibrium dialysis for T4 run direct assays for T4, which may be unreliable is, for instance, there are abnormalities in the binding protein for thyroid hormone called thyroid binding globulin, or TBG. Another thing that is important to keep in mind is that these assays, these direct assays, are biotin-related assays. And so that means that biotin, when used as a supplement, causes interference. And so whenever you see a falsely low TSH, or a low TSH and a high free T4 and T3, one of the questions that you need to ask the patient is whether they're taking supplements, and if these supplements include biotin. A lot of hair supplements include a fair amount of biotin, and so I usually ask my patients to refrain from taking biotin supplements 2 weeks before getting the blood work done. That's not the only drug that interferes with the thyroid axis. Prednisone, dopamine, dobutamine, and octreotide can cause TSH suppression. Iodine, for instance, the iodine that we give our patients for a CAT scan, can induce hyperthyroidism, and that's called the Yod-Basedow effect. So essentially, it's the thyroid that has a predisposition to develop hyperthyroidism, but doesn't develop it because there's not enough iodine around. And when we give patients this load of iodine, then the thyroid becomes hyperactive. Other medications that commonly cause hyperthyroidism include amiodarone, lithium, and some of the immunomodulators like IL-2, interferon alpha, alemtuzumab, and ipilimumab. So for patients that are on amiodarone and lithium, it is recommended that thyroid function is followed. Other medications can also cause hypothyroidism. So iodine again can, even though in some patients can cause hyperthyroidism, in some other cases it can cause hypothyroidism. The same way as lithium, tyrosine kinase inhibitors such as sunitinib, checkpoint inhibitors such as pembrolizumab and nivolumab, interferon alpha and IL-2. So you can see that a lot of these newer immune drugs can cause both either hyper or hypothyroidism. So it is important to keep that in mind as more and more patients are being prescribed these medications. Other things that are important to keep in mind is the issue that you can be interfering with GI absorption of medications. So for instance, bile acid resins, proton pump inhibitors, calcium carbonate, or iron sulfate can interfere with GI absorption. Thyroid hormone is one of the drugs that when we prescribe it, that has to be taken on an empty stomach. And so I usually tell my patients to have the thyroid hormone at the nightstand so they can, as soon as they wake up, take their thyroid hormone with a glass of water, and then don't eat or drink anything for 30 to 60 minutes. And then they can go ahead and have breakfast. That can have a significant impact on the free T4 levels if patients are not consistent with this. Other drugs can affect thyroid hormone metabolism. So for instance, phenobarbital, rifampin, phenytoin, carbamazepine can increase metabolism. So if a patient starts one of these drugs, for instance, they may need adjustments of the thyroid medications for those that are already taking it. Amiodarone, PTU, beta blockers, and prednisone can also affect thyroid hormone metabolism. PTU is propylthiouracil, which is actually a drug for treating hyperthyroidism. And then there's also alterations on the thyroid binding globulin, which in most cases, especially if you use a good assay for PT4, has become less relevant. Before, when we used to measure total T4 and not free T4, alterations in TBG were a lot more relevant. That's not the case anymore because the most common test we use after TSH is free T4. So what about screening? Who should we screen in terms of the older adult population for thyroid disorders? So when we see somebody who's having an illness such as frailty, depression, decreased cognition, chronic disability, those are the patients that need to be screened for thyroid disease. Other things that are commonly reported is involuntary changes in body weight, that is either weight loss or weight gain, constipation, diarrhea. I will come back to some of the symptoms in a little bit, but those patients should have their thyroid function checked. When an individual is doing okay, they may also need to be screened if they have a history of thyroid or autoimmune disease, which can be also causing depression and decreasing cognition. So those patients would also need to be screened. If a patient is not having any symptoms, it is controversial as to whether we need to screen that individual for thyroid disease. And so, for instance, the American Thyroid Association recommends a TSA check in adults over the age of 35 every 5 years. But the USPSTF and the American College of Physicians recommend no screening because they don't believe on the benefit of treating subclinical disease. Now, we know that hyperthyroidism, or the prevalence of hyperthyroidism, is fairly stable throughout the lifespan, but hypothyroidism has become more common, particularly in women with age. And so that's a rationale sometimes for being more aware and maybe screening more patients as our patients age, because the prevalence of the disease is more common. And what would be the signs and symptoms of somebody developing hypothyroidism? So dry skin, decreased sweating, cold intolerance, hoarseness, weight gain, constipation, paresthesia, so loss of hearing, those are less common, fatigue, weakness, and cramps, those are common, and depressed mood. And some of the signs that we can see include, in addition to those, is periorbital edema, mild to moderate weight gain, slow movements and reflexes, bradycardia, and alterations in skin, hair, and also nails. So at least in my practice, even when I see patients for other medical problems, these symptoms are fairly common. And so that's why I think it's sometimes when we say, well, asymptomatic patients shouldn't be screened. If you ask questions about this to my patient panel, then I don't know if you're going to have somebody who will say that they do not have any of these symptoms. A few things to keep in mind with reflexes. Sometimes you have to look at the relaxation phase. So not the way that the muscle contracts, but when it relaxes. And the knee, the patellar tendon reflex is not the most sensitive. Probably the Achilles tendon is better. I usually check the brachial tendon, and I find that to be pretty sensitive as well. Not mentioning here, but I discussed before, is also a goiter. So if you see somebody with a goiter, you have to also obtain thyroid function tests, and you have to suspect hypo or sometimes hyperthyroidism. So what about the older adults? Well, we can see the dry skin, hair loss, periorbital edema, and the cold intolerance. And sometimes when those are pretty severe, we have to be worried about severe hypothyroidism or mixed edema. Paresthesia, sometimes presenting with carpal tunnel, can be seen. Ataxia, again, decreasing in cognition, depression, apathy, and even sometimes psychosis can be a symptom of hypothyroidism in older adults. Myopathy and arthralgias, and bradycardia, pericardial effusion, and exacerbation of CHF can also be seen with actually both hypo and hyperthyroidism. This is an example of somebody with hypothyroidism who presented with cardiomegaly that was reversible upon thyroid hormone replacement. So how do we diagnose hypothyroidism? So the key feature in the lab values include a decrease in free T4. If your pituitary function is intact, that will also be shown with an increase in TSH, which is the way in which the pituitary is trying to stimulate the thyroid for increasing the secretion of thyroid hormone. And that is called primary hypothyroidism. If you have a low free T4 and TSH is normal or low, maybe in the normal range, but that's still inappropriately normal. And so you have to suspect that that patient has secondary hypothyroidism or central hypothyroidism, meaning a problem with the pituitary or the hypothalamus. If you have a normal free T4 and you have an increased TSH, because TSH is more sensitive than free T4, that can represent subclinical hypothyroidism. And so that is something that, depending if the patient is truly subclinical, meaning he has no symptoms or not, is whether we should treat him or not. We have to be cautious that there may be transient changes, either going up when you're recovering from an illness or going down when you're acutely ill. And so when somebody's ill, we have to follow these labs after the illness is resolved to really be able to interpret and make a diagnosis. Sometimes we can order antithyroid antibodies that could help in the diagnosis of Hashimoto's disease, for instance, which is one of the most common forms of hypothyroidism, an autoimmune thyroid disease. Because if you have some abnormalities and then the patient has antithyroid antibodies, then your suspicion for a true thyroid disease is higher. The causes include Hashimoto's, which I just mentioned, but there are others. And those are neck irradiation, for instance, in patients that have a history of lymphoma and head and neck cancer, inflammation of the thyroid, like thyroiditis, surgical removal of the thyroid because of goiter or thyroid cancer, drugs, which I mentioned before. And then the causes for secondary hypothyroidism, that is hypothalamic or pituitary disease, would include destructive processes such as tumor, granulomatous disease like sarcoid, TB, and then also the treatment that we use for tumors, so pituitary surgery or pituitary radiation or whole brain radiation sometimes. Head trauma is often overlooked, but is quite common cause of hypopituitarism. Now, thyroid is not commonly present unless you have a pretty severe head trauma, but it should also be kept in mind as we're evaluating patients, particularly after fall and if they had concussions or a more severe form of head trauma. Hypothyroidism in older adults is common. The prevalence is somewhere between 2 and 10%, and in most cases is subclinical. And subclinical, it may be a misnomer because we really are talking about TSH that is slightly above normal, so maybe between 5 and 10, and a normal free T4. So older adults can also have atypical and non-specific presentations. And so sometimes it's subclinical, sometimes the manifestations are neurobehavioral and cardiovascular, sometimes you see mixed edema, like edema, for instance, or colon intolerance. Other common signs and symptoms that are non-specific are falls, decreased cognitive function, and decreased mobility. So how do we treat hypothyroidism in older adults? So if a patient is symptomatic, usually warrants treatment. If the TSH is above 10, also warrants treatment, or if you have an increased TSH with positive antibodies, you also probably should treat. If a patient is asymptomatic and TSH is only slightly elevated between 4 and 10, and free T4 is normal, you can always monitor the patient without treating them. The goal should be to have a TSH in the normal range and not below the normal range. The treatment, which is levothyroxine, as mentioned before, has to be given fasting, especially in older adults. The treatment should start at a low dose, 25 to 50 micrograms per day, and then it can be increased slowly, maybe every 4 to 6 weeks, also by 25 or 50 micrograms, monitoring symptoms and monitoring TSH every 6 to 8 weeks. If somebody has severe symptoms, sometimes we have to titrate them faster, but we have to be careful with that because we'll be increasing metabolism, and that sometimes can exacerbate or make clinical a subclinical, for instance, coronary artery disease. And so we have to be careful when we titrate the medication in older adults. The requirement in older adults tend to be a little bit less, usually around 100, 110 micrograms per day. And we have to keep in mind, because of the issue of polypharmacy in the elderly, the number of medications that can either affect absorption or clearance of thyroid hormone. Following a TSH to make sure that if these drugs are started, stopped, or modified in dose, that the thyroid hormone axis remains normal is important. So now moving on to hyperthyroidism, the symptoms are somewhat the opposite of what we were mentioning before to some extent. And those are anxiety and nervousness, increased sweat, heat intolerance, dyspnea and palpitations, fatigue, weakness, weight loss, increased appetite, double vision or red eyes, diarrhea. And the signs include hyperkinesis, hands that are warm and moist, tachycardia or AFib, tremor, weakness, weight loss, decrease in the extraocular movements, lid retraction and lag, and thyroid enlargement. So the exam typically should involve inspection of the patient, looking at their face to see if you can see the thyroid. Of course, you have to do an palpation of the thyroid as well. To check for tremors, I usually have the patient extend their hands in front of them. If the tremor is very fine, sometimes if you put a piece of paper on top of them, you can actually see the paper shaking. That can help. Again, the brisk reflexes, especially the relaxation phase, the weakness, and then a cardiovascular exam to see if they're tachycardic or not. The extraocular movements is important to check. And for this, we also have to keep in mind what is the racial background of that individuals. We know that, for instance, the exophthalmos or protrusion of the eyes is more difficult or more challenging to see in minority populations. Individuals with Asian background tend to have sort of the eye more inside the eye socket, and so sometimes it can be missed. And individuals of African-American ancestry tend to have more protrusion of the eye normally. And so that could lead to either under or overestimation of the of exophthalmos. If your medical records has access to pictures, that can be helpful to see if there's been any changes recently. Or sometimes you can ask the patient to show you a picture of their face from a couple of years ago and see if there have been any changes. Some of the things that are specific to older adults is an increase in the rate of neurobehavioral and cardiovascular manifestations. So that is decreased appetite, weight loss, nausea or constipation. So measuring thyroid hormone should be part of the evaluation of patients with involuntary weight loss that tend to happen at this age. Depression, apathy, lethargy, and irritability can also be seen. Proximal muscle weakness and wasting, peripheral neuropathy, palpitations, AFib, and CHF. You notice that some of these things like depression or the weakness and fatigue are present in both hyper and hypothyroidism. And that's why it's important to get a lab evaluation in order to guide our diagnosis and our treatment. So Graves' disease, which is a type of hyperthyroidism, is an autoimmune disease, and the antibody that triggers this is called TSI. And that's a test that is available clinically, so you can actually request an antibody called TSI that will help you in making this diagnosis. In this case, patients will have a diffuse goiter in addition to the signs and symptoms of hyperthyroidism that I mentioned before. The ophthalmopathy, which I was talking about before, include proptosis and decreased extraocular movements. Chemosis, which is sort of an edema of the conjunctiva, can also be seen. And patients often complain about dry eye. Graves' disease can also affect the skin, and it can cause pretibial myxedema or thyroid acropathy, which affects the nails. This pretibial myxedema is different than, let's say, an edema that we see in patients with liver or heart failure, and can be more like a plaque. It's not scaling like a psoriatic plaque, but it can be present like a plaque rather than diffuse edema. So it's always important to do a foot exam on our patients and to ask them if they have any skin lesions that has developed recently. It's also important to realize that in the elderly, we may not see any of these symptoms. So we may see something else, like decreased cognition and falls or weight loss, and then they may have Graves' disease. So level of suspicion has to be higher. One example could be somebody presenting with atrial fibrillation with slow ventricular response, which can be seen in older adults. So this is how the patient that I presented initially came in. How are we going to diagnose hyperthyroidism? You will have a low TSH and an increased free T4. In very few cases, you will see sometimes only T3 is increased, and that's called T3 thyrotoxicosis. You will suspect this if you see somebody who has clinical features of hyperthyroidism, but free T4 is not elevated. And that will be a scenario where you will request a T3. If you have a low TSH and you have normal T4 and T3, you may be seeing a case of subclinical hyperthyroidism. But if the patient is symptomatic, that warrants treatment. TSI, which is this autoantibody, can help you in the diagnosis of Graves' disease. Graves' disease is not the only cause of hyperthyroidism, but if you see that the patient has these autoantibodies, then you have the diagnosis. Other tests that can help you in the diagnosis of hyperthyroidism include a thyroid scan or radioactive iodine scan, which it will be high if you have Graves' disease or if you have what we call a toxic nodule or toxic goiter. Toxic means that it's overproducing thyroid hormone. And so this will show us as hot nodules on the ultrasound. You may have also low to no uptake if the patient has a destructive form of thyroiditis. Let's say they have a virus, and that virus destroys the thyroid, which releases a lot of thyroid hormone into circulation. So the patient will be clinically hyperthyroid, but the scan will show low uptake because the thyroid is actually not making thyroid hormone. If somebody is taking thyroid hormone exogenously, for instance, it can be prescribed by some providers as a way to enhance weight loss, which is of course inappropriate, but that can cause a picture of hyperthyroidism with a cold scan. And then if the patient is taking iodine, that can also cause hyperthyroidism in a low scan. Sometimes we do that to our patients when we give amiodarone, which has iodine and also can induce thyroiditis, or for a CAT scan or a cath. Sometimes patients are just taking a lot of iodine in their diet, either because they eat a lot of seafood or because they're taking supplements. The prevalence of hyperthyroidism in the elderly somewhere between 0.5 and 2%. So it's still, fairly common, and most of them is subclinical. Some of this atypical subclinical presentation can cause patients to be simply just apathetic, depressed, or hypokinetic. Sometimes patients may present with weight loss, anorexia, weakness, and constipation. Sometimes a patient may present with dyspnea, slow atrial fibrillation, and CHF. Graves' disease is still the most common, so it is important to check TSI antibody. And toxic multinodular goiter is more common than a single nodule in the older adult, as it is T3 thyrotoxicosis, so that variant where only T3 is increased. What is the treatment of hyperthyroidism in older adults? So if a patient is symptomatic and the TSH is below 0.1, then treatment is probably warranted. Patients that are asymptomatic and have a normal free T4 and a TSH that is low, but not very low, so somewhere in the 0.1 to 0.3 range, is what we call subclinical hyperthyroidism. And treatment will be warranted if the patient has, for instance, atrial fibrillation, because we know that it can be worsened by thyroid disease, heart disease in general, osteoporosis, which is also a complication of hyperthyroidism, or cognitive impairment. So a clinical judgment is important here in looking at the patient and other comorbidities to make a determination as to whether the patient needs treatment or not. At a minimum, the patient will need close follow-up for this. For patients that are symptomatic or that have had radioactive iodine before, beta blockers can ease some of the symptoms like the tremor, the nervousness, the tachycardia, and the preferred agent is the propranolol in doses of 40 to 120 milligrams a day. We also use anti-thyroid medications that sort of stop the production of thyroid hormone. Metimazole is the most common drug used for this purpose, and the dose is somewhere between 5 and 15 milligrams a day. For patients that are intolerant of this, or sometimes if there are compliance issues, we can use radioactive iodine at a low dose, and so that will cause the decrease of thyroid function. Most of the time, that will end up causing hypothyroidism. So patients have to understand that if they receive this treatment, that they may still need to be taking medication, which will be thyroid hormone. It's just that thyroid hormone is in general better tolerated. It has a better safety profile than metimazole and propranolol. These medications, metimazole in particular, requires checking a CBC and checking liver function tests regularly because of rare but complications that I have seen that include agranulocytosis and also liver failure. The other complication of the drugs could be Stevens-Johnson syndrome, so a severe allergic reaction. So I usually warn the patients that they start on this drug about these three things. Now moving on to nodules of the thyroid. So we have different options. So you can have a gland that has more than one nodule, and that's what we call multinodular goiter, or glands that have a solitary nodule. Multinodular goiters are usually benign, but you may have a suspicious nodule in there that can be cancerous. So it can be ruled out, cancer can be ruled out simply because you have multiple nodules. The majority of solitary nodules are non-palpable, and the majority are benign and cold, but some can be cancerous. So that's something also that we have to consider. And that the chance of something being cancerous, a nodule being cancerous, increase in the older adult. Cysts are usually benign and colon scan. So those usually are not worrisome. So as I mentioned before, sometimes you can see patients that are taking supplements. Here are two examples. or that are given iodine for medical procedures, and that can lead to hyperthyroidism. It can also lead to hypothyroidism, but more worrisome, it can lead to hyperthyroidism. So it is important to do a good history taken on these patients to look at these two factors. Regarding the management of non-toxic multinodular goiters, usually you will ask your patients about any local compressive symptoms. So do they have difficulty swallowing, or hoarseness or cough, for instance? There are cosmetic issues. In some cases, it can be very obvious. And there's an increased risk of iodine-induced hyperthyroidism. In general, as I was mentioning before, these multinodular goiters have a low risk of malignancy. If the patient is not having local compressive symptoms, there's usually no treatment indicated for goiter. And TSH suppression with levothyroxine, so giving levothyroxine to make the TSH low, is not recommended because it's first, it usually doesn't cause enough shrinkage of the goiter, and second, because it causes, it increases the risk of symptomatic hyperthyroidism. And so the patient may end up having AFib or osteoporosis or unintended weight loss or muscle weakness as a result of this. The treatment, if the patient has local compressive symptoms, or if there's a risk of being a malignant nodule inside that goiter, is surgery. So here's an example of a thyroid nodule that you can see there on top of the clavicle. I usually ask the patient to swallow, and I see how their neck moves. And sometimes that can help you identify the thyroid gland if it's enlarged, in a nodule within the thyroid gland in particular, if it's visible. Solitary thyroid nodules are also fairly common, and the prevalence is about 5%. It's palpable in about 7% of women and about 2% of men. And the prevalence is increased with neck irradiation in the elderly, to the point that if you look at autopsy series, about 50% of people will have a thyroid nodule. So now that we're doing ultrasounds of the neck and CTs of the neck for other purposes, then a lot of these are being detected incidentally and are being referred for evaluation. The good thing is that the majority of them are benign, but not all of them. So about 15% can be malignant. And so evaluation is warranted. And this graph is alluding to what I just mentioned, that you definitely will palpate more nodules as our patients' age increase, but that increase is far greater if you rely on ultrasound. So what are those patients that have an increased risk of thyroid cancer when we find a nodule? So male individuals to age extremes, so either you're a very young or an older individual, history of neck irradiation, again, somebody who's had head and neck cancer, lymphoma, for instance. For those individuals that are probably at least 70 years old, they used to be part of the treatment for tonsillitis, or when somebody had increased tonsils. So their doctors will, and this is probably in the 40s, they will irradiate their neck. And so now they're at a higher risk of thyroid cancer. Also, apparently in that era, there was some sort of, I guess it's a precursor of video games, where you will go to a store and look at some story as if it was like a movie, and that exposed people to radiation. So for somebody who was around in those years and is being evaluated for cancer, for a thyroid nodule, these are questions that I typically ask. Of course, a family history of thyroid cancer, particularly if you're suspecting medullary thyroid cancer or multiple endocrine neoplasia. Recent changes. So for instance, if the patient suddenly noticed an increase in the size, especially if it's greater than 4 centimeters, that would be worrisome for thyroid cancer. If it's hard on palpation, if it's causing hoarseness, or if it's fixed to the skin or to other tissues, if it causes dysphagia, dyspnea, or if you find lymphadenopathies or masses elsewhere. Negative lymphadenopathies are the most common site for metastases for thyroid cancer. The management of a thyroid nodule involves surgery if it's suspicious for cancer, but this usually is done after fine needle aspiration biopsy, which is these days done almost always under ultrasound guidance. If the nodule is greater than 1 centimeter and suspicious ultrasound, then the biopsy is indicated, or if the nodule is greater than somewhere between 1.5 to 2 centimeters and is not suspicious on the ultrasound, sometimes that's biopsy as well. Particularly in the elderly, multinodular goiter is fairly common, about 60 to 90%, depending on the series. You may have increased autonomy or increased risk for hyperthyroidism. It may be resistant to T4 suppression, so that's why it's discouraged. And it increases the risk of iron-induced hyperthyroidism. So we have to be careful when we have a patient with a goiter and we're going to prescribe a procedure that involves the administration of iodinated contrast. Solitary nodules are also very common. And there's an increased mortality with well-differentiated thyroid carcinoma in the elderly. There's also an increased prevalence of lymphoma and anaplastic thyroid cancer, and increased incidence of hyperthyroidism with TSH suppression. So you can see here sort of the relationship between the incidence and the death rate of thyroid cancer with aging. So as we age, the prognosis of having thyroid cancer obviously worsens, and the incidence also increases. So the take-home messages. Thyroid disease in the elderly is common, so we have to think about it when we see our patients. Hypothyroidism is more common than hyperthyroidism. Subclinical is more common than overt disease, and that usually refers to changes, small changes in TSH with normal 3T4, and with symptoms that are not consistent with either hyper or hypothyroidism necessarily. We have to understand that because our older patients have multiple comorbidities, they may have the clinical picture may be different, may be confounded and attributed to old age. And so we need to have a higher level of suspicion when we're evaluating these patients. It's important to measure both 3T4 and TSH in those individuals that are non-healthy. And we have to remember that if you're going to be measuring somebody who's undergoing an acute illness, that the TFTs have to be interpreted with caution because they can be misleading. And so in most cases, it is recommended that we follow those up over time until the patient recovers before we implement any treatment. When we diagnose hypothyroidism, we're going to replace somebody with thyroid hormone. We start slow, and we start low and go slow, and we monitor the patient to make sure that we don't unmask cardiovascular disease. For for instance, that because of the low metabolism, it was subclinical. And then, of course, and this is, I think, true for a lot of the things, a lot of the diseases that we manage in the elderly, is that the comorbidities may compromise therapy. It may be worsened by inappropriate treatment, exposed to drug interaction, and poor compliance. So these are things that I revisit with my patients at every visit about the compliance, the changes in the medications, and try to interpret the labs that I get and taking those factors into account. Another take-home message is that if you have well-differentiated thyroid cancer, the prognosis is worse in the elderly than in young individuals. So now coming back to our case, so we had a 70-year-old female that was admitted to the ICU with CHF exacerbation, that had a diagnosis of AFib with a heart rate of 58 and a blood pressure that was kind of low. And the patient had a history of having had a cardiac cath showing clean coronaries a month before. So that meant that the patient had this load of iodinated contrast a month before. So the exam was consistent with atrial fibrillation and CHF exacerbation, but the patient had a goiter. So we see a patient with a goiter in a history of recent administration of iodinated contrast. That should raise our suspicion of measuring thyroid hormone for the risk of hyperthyroidism. So in this case, TSH was borderline low and 3T4 was high. The reason why TSH probably was just borderline low is because TSH takes up to 8 weeks to change. And so if this was an acute event, which is probably what happened because it was all triggered by the iodinated contrast, then TSH didn't have enough time to change. 3T4, that has a shorter half-life, did go up already. So you will see a 3T4 that is high and the TSH change is lagging behind. And then the ultrasound to show diffusely enlarged thyroid with a 1.1 centimeter nodule. So this nodule, as I was mentioning before, is actually fairly common in individuals with older individuals, especially those with goiter. We did not perform a scan on this patient, and the reason why we did not perform a scan is because the patient had received this big dose of iodine. So given radioactive iodine will not be of use because the thyroid is probably saturated for the next 3 to 4 months with the iodine that she received during the study. So the result will be a low uptake, but that doesn't mean that that patient has a low uptake of iodine. It may be that it already took everything that it needed. FNA was not performed. There were no features suggestive of cancer, and so that workup was deferred. And the TSI, that antibody for Graves' disease, was negative. So the patient was treated with methimazole, this anti-thyroid medication, and beta blockers after fluid repletion. And her symptoms improved over the ensuing days. Okay, thank you very much. I am looking forward to answering any questions you might have.
Thanks so much, Dr. Garcia. That was great. A really comprehensive review of thyroid disorders. Really appreciated that. And the case study brought it all together. A question here from Bonnie is about the length of time thyroid suppression is recommended post-thyroid cancer.
Yeah, and that there's been sort of a shift in, I would say, the last decade on that in terms of the time for suppression as well as the degree of suppression, and that it has to be individualized to each patient. Essentially will depend on the risk of recurrence. So the things that you will have to take into account is the type of the tumor, the staging of the tumor, and also sort of the clinical course and the age. So if you have a small tumor and you are low risk, you may need no suppression at all. Or the level of suppression that you may need, for instance, will be only to keep your TSH in the low end of normal. If you have a tumor that has a higher risk of recurrence, more advanced stage, a higher risk individual, you will want to have that suppression maintained and then follow that patient over time.
And this is a great question for an endocrinologist. What guidelines for screening or assessment before starting a GLP-1 agonist for diabetes in patients with a family history of thyroid cancer?
Yes, so unless the patient, a small minority of individuals with thyroid cancer have a type of cancer called medullary thyroid cancer. And so if a patient has that tumor, that's when you will probably want to be careful. For the vast majority of thyroid cancers that are non-medullary thyroid cancer and patients have no history of MEN, then it's probably not warranted.
And does the HPA axis play a role in the link between thyroid disease and diabetes?
So there's a condition where you may have autoimmunity that is not only limited to the thyroid, but can also affect other endocrine organs, such as the adrenal and the endocrine pancreas. And so that would be potentially the link if you see somebody with one of these autoimmune conditions and linked to another. We typically don't screen patients simply with Hashimoto's thyroiditis or with Graves' disease for these other conditions unless we see something else.
And I was wondering if Geneva could, there was a question about how long does a remission, and then the rest of the question didn't finish.
I think I can see it. It says, how long does remission last for Graves' disease after treatment with methimazole?
Oh, great.
And,
okay.
Yeah, and so Graves' disease usually responds to methimazole, but unfortunately, most of the time, when you stop the methimazole, the disease comes back. And so the patient has to be taking the methimazole long-term.
Okay.
And so sometimes that weighs on the patient's decision as to when to decide to go for the radioactive iodine ablation of the thyroid. And so, and I usually tell patients that they don't, this potentially could be an issue, but they could also make a decision later on in the disease process. So they could start taking methimazole, and if they tolerate it, they may take it for a year and a half, then we can try and take them off. And if the disease recurs, and if they don't want to keep coming back every 3 months to get labs, and they don't want to be on methimazole, then at that point, they could decide to go for radioactive iodine ablation. The caveat is that they will still have to be taking a pill a day. And so the difference is that instead of taking methimazole, they will be taking thyroid hormone. And thyroid hormone is usually better tolerated. It doesn't cause liver problems or potentially allergies that methimazole can cause. And if you forget to take it for a day or two, it's probably less, the symptoms are going to be less severe than if you don't take methimazole. And so a lot of patients end up switching and going to a radioactive iodine after being for a period of time taking methimazole. But other patients choose to stay on it, and it's usually not a burden for them. So that is also a suitable option.
Could you please give more information about head trauma and TFTs, especially MTBIs in older adults?
Yes, and this is an area that I'm, as a VA physician, I'm studying, although the majority of the TBI that I see are not in the elderly, are younger individuals that were exposed to blast or they had an injury during training, but are, were in the conflicts in Iraq and Afghanistan. So they're approaching 50, some of them. So eventually they will become geriatric patients, of course. We know that when you have a TBI, there's approximately a 20% risk of developing pituitary hormone dysfunction. It doesn't seem like the severity of the TBI is necessarily associated with that risk. And so patients with a concussion, when case series, including one that we published recently, have been looked at, they have a similar prevalence to those studies that looked at patients with moderate to severe TBI. It's important to know that whenever you have a head trauma, you're going to have transient changes in hormones. And so you will see some hormone deficiencies perhaps acutely. And if you measure them again in 3 months, in 6 months, and at a year, the type and number of the prevalence of these conditions will change. And so it is usually not recommended to treat these, except perhaps for adrenal insufficient cortisol deficiency until 1 year out of the event. Thyroid hormone is not very commonly affected. And the most commonly affected are growth hormone, which is less relevant in the elderly, given that we don't replace usually growth hormone in the elderly, but also cortisol deficiency. So from a clinical point of view, that would be my recommendation is if a patient had a concussion and if the patient is having symptoms of fatigue, of course, if they have a more severe TBI as well, that the adrenal function is evaluated with at least a morning cortisol. And if it's not above 10, that the patient undergoes, or 12, the patient undergoes a stimulation test to make sure that that patient is not adrenal insufficient. If the patient remains symptomatic 1 year out, then measurements of all the other hormones will be replaced. You can measure it earlier, but then you have to remember that the changes you're seeing at 3 or 6 months or acutely may not be permanent. And so if you're going to choose to replace somebody, let's say for the thyroid hormone initially, at 6 months after an injury, it's probably warranted for you to make a trial of stopping that hormone replacement at 12 months and see if the axis has recovered on its own. In those patients, I usually also do a pituitary MRI, not because the TBI will necessarily cause pituitary disease, but just to make sure that I'm not missing something else, like a pituitary tumor. Not on everybody with a TBI, but on those individuals that are having abnormal hormone levels in the setting of TBI.
Really interesting. Beth is wondering, in the case that you presented, what were the symptoms that prompted the patient to come to the ER, and which symptoms would differentiate the diagnosis of CHF from thyroid?
Yes, so in this case, what triggered the endocrine evaluation was the fact that the patient had a goiter. And so the physical exam is important. It is also, so it wasn't, the clinical presentation was AFib and CHF exacerbation. But any individual that presents with AFib should probably have a TSH measure just to make sure that they're not having thyroid disease, hyperthyroidism in particular.
Any other questions, folks? I think I've been through the ones that have come in so far. Really appreciated your helpful responses, Dr. Garcia.
Thank you. My pleasure.
Okay, I think then we can close out this session. This was great, really appreciate it. To everyone, we will fix the glitch on the evaluation survey, and I hope you'll be getting a new link probably tomorrow. So watch for that. And thank you to Dr. Garcia, and we'll see you next week. Everyone.
Thank you.
Thanks.